Good afternoon, everyone. I'm Lohith, Vatti. I'm one of the residents at UChicago. My project is titled Perioperative Dexamethasone Effects on Functional Outcomes and Safety in Isolated Lower Extremity Long Bone Fracture Fixation. Dexamethasone is a corticosteroid medication with both anti-inflammatory and immunosuppressive effects used across multiple subspecialties. And in arthroplasty especially, the literature is especially robust, demonstrating reduced length of stay, improvement in post-op pain and nausea scores, and lower rates of opioid consumption. The work done in arthroplasty has also affirmed its safety with respect to hyperglycemia and infection rates. Small-scale studies exploring steroids for trauma patients show modest improvements in post-op pain and early functional outcomes without increased complication risk, but are limited by size and external validity. The goal of our investigation was to understand the role of perioperative dexamethasone in trauma patients by assessing outcomes of patients undergoing a fairly common surgery. For the methods, a retrospective cohort study was designed to analyze cases of adult patients with isolated femur or tibia fractures treated with full-length intramedullary nails between May of 2018 and 2022. The exclusion criteria are listed. An a priori POW analysis performed to detect 80% of the previously measured effect on length of stay necessitated about 83 patients per group. 201 patients were included in our cohort, 88 received dexamethasone and 113 did not. The primary outcome was hospital length of stay, defined as the days of consecutive admission postoperatively. We also examined a number of secondary outcomes, including pain, nausea, glucose levels, ambulation, time to union, non-union rate, and 90-day complications of infection and reoperation. Statistical analysis was conducted with Wilcoxon rank sum, chi-square, and Fisher's exact tests, and p-values were adjusted for multiple comparisons using the Benjamini-Yaculti procedure. And afterwards, we did a Poisson regression as well. Table 1 represents a summary of our demographic data. The only difference between our two groups was sex distribution. Moving to the results, there was no differences in length of stay between those receiving dexamethasone perioperatively versus those not. For secondary outcomes, the DEX group had lower morphine equivalent utilization on post-op day 0 and days 0 through 3 on average, and the results, however, did not reach statistical significance after p-adjustment. No additional differences in secondary outcomes were identified. Poisson regression analysis also revealed no effect of dexamethasone on length of stay. Interestingly, BMI was the only covariate with a significant effect. For complications, the DEX group had a non-significant lower rate of superficial infection. No other differences were found in rates of non-union, average blood glucose, deep infection, or reoperation. Mature literature in traumatology pertaining to dexamethasone is limited, likely due to the immunosuppressive and metabolic effects of steroids sort of heeding caution to its broader adaptation. This is a population where patients are already in a pro-inflammatory state with limited perioperative optimization and separate risk factors. Our investigation demonstrated no difference in length of stay within a subset of trauma patients treated with this medication. There may be a potential for modest reductions in post-op opioid consumption, but after adjustment for multiple covariates, we did not find a statistically significant difference. Between groups, though, there were no significant differences in other secondary outcomes, including complication rates, which can suggest a positive safety profile. And this agrees with some prior trauma publications pertaining to geriatric patients with intertroch femur fractures, and that length of stay changes were not found, and neither were differences in major complication rates. Our data broadens the scope to a younger population undergoing common fracture fixation. Some of our limitations were pertaining to the retrospective nature, as well as what may be inadequate power to detect differences in secondary outcomes driven further by losses to follow-up and short length of stay, limiting our sample size. Despite this, we achieved adequate power for our primary outcome, and further investigations with broader enrollments in randomized controlled trial models may advance our understanding for the role of steroids in trauma patients. I'd like to thank my co-authors, and I look forward to any questions you may have.